Hello, my name is Andrew Joshua Kobitz, and I'd like to talk about this presentation outlining tumors of the spine, spinal canal, and spinal cord in children that is to accompany our chapter in Humans and WIN, a neurological surgery. As an introduction, tumors in and around the spinal column for this chapter and classically are categorized according to location, with intramedullary spinal cord tumors being discussed first, intradural extramedullary tumors, then extradural tumors, and then tumors of the spinobonal column. This chapter will review the epidemiology, pathology, symptomatology, treatment, and outcomes for patients with tumors in these locations. Pediatric spinal cord tumors occur in 0.1 to 0.26 per 100,000 patients. And of all central nervous system tumors, 5.1% occur within the spinal cord or the cauda equina, with only 4.2% of these lesions as intramedullary spinal cord tumors. Roughly, there's about 170 to 180 intramedullary tumors within the United States annually, but there does not seem to be a predilection for gender overall for these tumors, but we'll get into the individual nuances of each of these lesions. Intradural extramedullary tumors occur in only about 25% of all spinal tumors and are primarily either nerve sheath or meningiomas, but we'll talk about other varieties as well in the coming slides. Annual incidence for nerve sheath tumors of both the cranial and spinal nerves occur in about 0.27 per 100,000 patients. Tumors of the meninges occur a little bit less, 0.2 per 100,000 patients. Spinal inclusion cysts, which include dermoids and epidermoids, as well as metastatic medulloblastomas, can also be seen intradurally extramedullary, and very rarely ATRTs have been reported as extramedullary tumors as well. There appears to be no sex predilection for these spinal nerve sheath tumors, meningiomas, or inclusion cysts in children. Extradural tumors in children are most commonly neuroblastomas, which in its mature form is called a ganglioneuroma, lymphomas, chloromas, which are myelogenous leukemias, as well as metastases. Neuroblastoma counts for 15% of all neoplasms within the first 4 years of life. Epidural neuroblastomas occur during infancy, whereas epidural lymphomas, leukemias, and metastatic disease tend to occur in late childhood. There's a strong preference for epidural disease in children with leukemias, lymphomas, and metastatic disease. Moving on to spinal column tumors, tumors of the pediatric bony spine account for less than 50% of all spinal tumors. Osteoid osteomas and their larger form osteoblastomas, osteochondromas, aneurysmal bone cysts, and Langerhans cell histiocytosis are the most common benign lesions encountered. Osteoid osteomas and osteoblastomas occur for 9% and 1% of all benign spinal column tumors, respectively. Osteochondromas, while the most common bony tumor in children and adolescents, only occurs for about 1 to 7% within the spine, and aneurysmal bone cysts occur between 11 and 18 years of age. Malignant tumors of the bony spine include Ewing sarcoma, mesenchymal sarcomas, osteosarcomas, angiosarcomas, giant cell tumors, teratomas, and chordomas. Ewing sarcoma is the second most common primary bone malignancy in children and adolescents, and while osteosarcoma is the most common malignant bone tumor in children, it rarely involves the spinal column. Osteosarcoma, Ewing sarcoma, and giant cell tumors most commonly occur in adolescence, while chordomas and teratomas can occur throughout childhood. Now moving on to the pathology and the pathological analysis of each of these individual subtypes of tumors. We're first going to move to the intramedullary spinal cord tumor group, and we will begin with astrocytomas. Anaplastic astrocytomas and glioblastomas have broader zones of infiltration into the spinal cord parenchyma than lower grade astrocytomas, grade 1s or grade 2s. However, both can have extensive border zone infiltration into the spinal cord, making complete resection very difficult. These lesions, high-grade lesions, as well as low-grade lesions, can be seen associated with BRAF mutations, and when present, these BRAF amplifications, and less commonly the BRAF KIAA 1549 translocations, can be seen. BRAF is a member of the serine threonine kinase protein family and has downstream effector activity on RAS in the RAS, RAF, MEK, ERK signaling cascades. P16 and P10 gene mutations are also present within these lesions. Moving on to mixed glial neuronal tumors. Mixed glial neuronal tumors are the second most common intramedullary spinal cord tumors in children and young adults, and gangliogliomas are the most common subtype. Margins are infiltrative, and there's no plane between them and the normal cord, similar to astrocytomas. Pathology demonstrates large neuronal cells with vesicles around the nucleus that stain for synaptophysin, and tumors are GFAP positive, and a subset demonstrate EGB positivity as well. Oligodendrogliomas vary from their typical appearance intracranially to those with astrocytic components with oligodendroglial cells of varying densities. Microdeletions of the NF1 gene without germline alterations, as well as activating mutations in the fibroblast growth factor receptor gene, FGFR1, have also been reported in these lesions. Next, ependymomas are the most common intramedullary spinal cord tumor found in adults. However, only about 10 to 15% of lesions in children. Grade 1 subtypes include myxopapillary ependymomas, which we will discuss separately. Grade 2 lesions are cellular, clear cell, tanocytic, and papillary ependymomas, which are all considered benign. Grade 3 lesions are anaplastic ependymomas and are much more malignant. Central locations within the cord with sharp demarcation from the parenchyma differentiate these lesions from previously discussed lesions within the spinal cord. Correlations with the NF2 suppressor gene on 22q12.2, which encodes the protein Merlin, have been implicated in these lesions. Myxopapillary ependymomas, unlike other lesions within the spinal cord, represent only about 13% of all spinal ependymal tumors, with a small percentage in children. Unlike other lesions, they're found in the cauda equina, cona medullaris, or in the frenulum terminale region, and rarely do they metastasize. Pediatric myxopapillary ependymomas have a predilection for dissemination throughout the CSF pathways. They are encapsulated, well-circumscribed, soft gray or tan lesions, and microscopically there is perivascular hyalinization, mucoid degeneration, and papillae are present with round to oval nuclei around central cores of acellular hyaline material. They are positive for vimentin, GFAP, S100, and negative for cytokeratin. Moving on to hemangioblastomas and cavernomas within our intramedullary spinal cord tumors group. These lesions are closely packed blood channels surrounding groups of cells containing eosinophilic cytoplasm that is richly vacuolated. Nuclei are hyperchromatic. 25% are associated with mutations in the VHL gene on chromosome 3p25 and 26, which is transmitted in an autosomal dominant fashion. This mutation targets hypoxia-induced factor 1A, which regulates cell metabolism and vascular proliferation. Cavernomas are classically described as mulberry-like in appearance due to their purple color and irregular surface that contain vascular sinusoids. Calcifications or hematomas may also be present, and they demonstrate multiple small vessels that are tightly opposed to one another without intervening tissue seen on pathology. Meningiomas can range from grade 1 to grade 4. The list of grade 1 lesions, 2, and grade 3 lesions are located on this slide for review and for reference. Classically, calcifications can be seen in meningiomas, and they are associated with neurofibromatosis type 2, Gorlin syndrome, radiation therapy, and have NF2 and SMARS1 mutations. Patients with NF2 have increased risk of meningiomas in the spinal canal and on the optic nerve sheath. Schwannomas are well-encapsulated lesions with nerve fibers stretched around the tumor capsule, unlike neurofibromas, which we'll shortly discuss. Pediatric schwannomas occur in patients with neurofibromatosis types 1 and 2, with more commonly seen in NF2. Mutations on NF2 gene, LZTR1 gene, and the SMARCB gene are also associated with these lesions. Pathologically, we see highly dense cellular zones known as Antoni A areas, which are present and pathognomonic for these lesions. Loosely organized areas with lymphocytes, lipid-laden histiocytes, and small vessels are also seen, and these are called Antoni B areas. Within also the Antoni A areas are bands of fusiform nuclei intermixed with clear zones lacking nuclei, and these are called Verroque bodies. These lesions are positive for S100 protein, and unlike meningiomas, lack reactivity to EMA. Neurofibromas are not encapsulated and involve the entire nerve in cross-section, unlike schwannomas. These are dumbbell-shaped lesions that extend along the spinal nerve root from the spinal canal into and through the neural foramen. They are tan white on appearance without areas of degeneration as seen in schwannomas. Schwann cells, fibroblasts, and nerve fibers admixed with mucopolysaccharides, fluid, and fibrous material are characteristic for neurofibromas. A myxoid matrix where collagen is arranged in a disorganized fashion, often likening an appearance of shredded carrots, are associated with neurofibromas. These lesions stain for S100 less intensely than schwannomas and express EMA, similar to meningiomas, as well as CD57. Malignant peripheral nerve sheath tumors exhibit preferential differentiation towards one of the cellular nerve sheath components, either perineural cells, Schwann cells, or fibroblasts. Roughly 10% of these tumors arise in patients with previous radiation exposure, either environmental or therapeutic. These lesions are associated with NF1 and is the most common malignancy in this disease entity. Spinal inclusion cysts, including dermoids and epidermoids, are lined by stratified epithelium in dermoids that's similar to epidermal cysts. However, in dermoids, hair follicles, sebaceous glands, and other epidermal adnexa may be present. Blood vessels that surround the tumor are required to be removed carefully. However, they rarely invade these lesions and sometimes can be removed without needing to be sacrificed. Yellowish fluid is composed of laminated keratin within these lesions and may also contain desquamated epithelium and sebum secreted by the glands located within dermoid inclusion cysts. ATRT lesions demonstrate rhabdoid cells with eccentric nuclei and eosinophilic cytoplasm with hyaline inclusions with immunohistochemical staining for synaptophysin and CAM 5.2. Deletions of the SMARCB1 gene or the SMARCA4, INI1, and rarely BRG1 genes are seen in these lesions. ATRTs are tumors of very young children with a 75% male predominance and mostly located within the cervical spine. Moving on to extradural tumors, we'll discuss neuroblastomas, which demonstrate small, uniform cells, hyperchromatic nuclei, and scant cytoplasm. Homerite rosettes with desmoplasia are seen in these lesions. Neuroblastic tumors also contain reactive Schwann cells that are influential in the differentiation and maturation of these tumors. Neuroblastomas demonstrate avid staining of primitive neuroepithelial markers such as NSE, chromogranin, and synaptophysin, as well as S100 immunoreactivity. Amplification of the MYCN gene is seen in roughly 25% of neuroblastomas. Other associated novel mRNA transcripts include a glypican-2 cell surface heparan sulfate proteoglycan protein that is associated with these lesions that binds to GPI and correlates to overall poor survival with neuroblastomas. Next, lesions of the spinal column include osteoid osteomas and osteoblastomas. Nidus of osteoblasts, usually yellow to red in gross appearance, create the core of these lesions. They produce osteoid and woven bone with trabeculae and a fibrous connective tissue rim. Osteoblastomas are larger than osteoid osteomas, greater than 1.5 centimeters, and contain large vascular sacs, reactive giant cells, and have a tendency for local invasion. Osteochondromas present as smooth, shiny lesions on the surface and consist of an internal core of maturing bone overlaid by a thin fibrous capsule of benign cartilage with a smooth surface. Thick cartilaginous caps or spindle cell proliferation at the cartilage-bone interface may suggest a malignant transformation. Aneurysmal bone cysts demonstrate multiple anastomotic cavities filled with non-coagulated blood and or serous hemorrhagic fluid. These cavities lack formal endothelial lining and are often filled with lymphohistiocytic elements, giant cells, and siderophages. Septae demonstrate reactive osteogenesis with an underlying calcified fibrochondroid matrix. Langerhans cell histiocytosis demonstrates dendritic or Langerhans cells with associated grooved nuclei and eosinophilic cytoplasm. Medullary expansion and destruction of bone are commonplace owing to the classic flattening of vertebral bodies seen in these lesions. They are S100 and CD1A reactive. Ewing sarcoma demonstrates sheets of small cells with high nuclear to cytoplasmic ratios. The cytoplasm in these tumors contains glycogen as detected on a PAS stain and is eosinophilic. Generally, staining for CD99 or MIC2 may also be expressed, as well as other neuron-specific markers such as enolase, synaptophysin, and S100. Osteosarcomas are large, bulky tumors that contain areas of hemorrhage and cystic degeneration. Most have hyperchromic nuclei, and giant cells are commonly seen in a lace-like structure with cartilage and fibrous tissue interwoven. Vascularized subtypes of osteosarcoma consist of multiple blood-filled cysts. Angiosarcomas are lesions with irregular shapes and poorly differentiated borders. They are well-formed vascular channels lined by tumor cells. Often they have CD31, CD34, FLI1, and ERG immunoreactivity. Over 65% of these lesions demonstrate cytokeratin staining. Giant cell tumors histologically demonstrate multinucleated osteoclast-type giant cells, which may be large and frequently undergo cystic degeneration. Uniform oval mononuclear cells with indistinct cell membranes may form a syncytium in these type of tumors. Hemorrhage, hemosiderin, and necrosis can commonly be seen. Chordomas are classically described as having a phyllosapherous or bubbly type of cell that are arranged in small clusters or chords within a myxoid matrix. They are strongly enhancing and reactive for S100 and keratin, and immunoreactivity to brachiuria has been shown to be both a sensitive and specific marker, aiding in the diagnosis of these lesions. Teratomas are mixes of solid and cystic components with multiple varying cell lines, including ectodermal, endodermal, and mesodermal elements. Primitive cell lines with varying degrees of mitoses are present on pathological examination. Now moving on to the presentation of these individual tumor subtypes. Starting with intramedullary tumors, the most common symptomatic presentation is motor regression. This is followed by pain, gait abnormality, dysesthesias, and progressive kyphoscoliosis. Signs of myelopathy is frequently seen in patients. These lesions present with nausea and vomiting if at the cervical medullary junction. Neck pain with or without radiation can be present if these lesions are located within the cervical spinal cord. Parents may report switched hand dominance in children with isolated lesions on one side of the spinal cord. When the sensory abnormalities are symmetric, the diagnosis of ependymoma should be suspected, as these lesions grow symmetrically from the center of the spinal cord. In the thoracic spine, first symptoms are pain and progressive scoliosis, and at the conus, early manifestations may involve bowel and bladder symptomatology. Next, intradural, extramedullary, and extradural tumors may present with weakness followed by pain as the most common symptom, occurring in roughly 40 to 50% and 30 to 50% respectively. There can be a radicular component to this pain, but dysesthesia is usually unusual. Incontinence will be present in about 20% of patients with either intradural or extradural extramedullary tumors due to compression on the spinal roots that control this function. The most common presenting complaint of children with a tumor in their spinal column is pain followed by weakness. Pain can be limited to the back, presumably due to dural or periosteal irritation, or may be radicular. Malignant spinal column tumors present sooner, typically with a 3 to 10 month history of pain or weakness, as opposed to benign lesions, which typically present after 6 to 20 months of symptoms. Next, we will discuss the diagnoses of these individual subtypes of tumors, starting with intramedullary spinal cord tumors. In children, over 90% with a mass lesion will either have an astrocytoma, a ganglioglioma, or an ependymoma. Hemangioblastomas or primitive neuroectodermal tumors are also remote possibilities and should be considered in the differential diagnosis. When the size of the lesion is not consistent with the degree of edema, other inflammatory processes should be considered, such as multiple sclerosis or transverse myelitis, among other pathologies. Scanning of the brain in a delayed repeat imaging format at 3 to 6 months will clarify the situation between inflammatory processes as from different tumor subtypes. Starting with astrocytomas, on MRI they will enlarge the spinal cord's diameter and on average extend over 4 spinal segments. The epicenter will be eccentric compared to ependymomas. On T1 weighted imaging, the majority, over 80%, will be hypointense, with about 20% being isointense. On T2, they will appear hyperintense, and with gadolinium, the tumors will enhance in all but the rarest occasions. Mixed glial neuronal tumors, or oligodendrogliomas, encountered rarely in children. Grossly, they are seen on radiograph as a similar appearance to other gliomas, and they tend to infiltrate the surrounding normal cord parenchyma at their margins on imaging. Ependymomas, unlike astrocytomas and gangliogliomas, arise centrally and expand the cord symmetrically. The majority of non-myxopapillary ependymomas will be isointense or hypointense on T1 imaging, whereas myxopapillary ependymomas will either be iso or hyperintense. T2 weighted imaging for both subtypes show hyperintensity, and cysts are common, usually intratumorally. Myxopapillary ependymomas are iso to hyperintense on T1, as previously discussed, and hyperintense on T2. They enhance vividly with contrast and commonly have an intratumoral hemorrhage demonstrated due to their high vascularity. Hypodense areas on T2 weighted images suggest remote hemorrhages. On X-rays and CTs, expansion of the spinal canal and a scalped posterior surface to the vertebral bodies may be seen. Hemangioblastomas and cavernomas are small intraaxial lesions that are typically 1 centimeter in diameter. On T1, they will be hyperintense centrally, with multiple areas of differing signal intensity correlated with hemorrhages and associated cysts peripherally. Surrounding regions of hypointensity is characteristic, with vividly enhancing mural nodules, and homogeneous in smaller tumors and heterogeneous in larger ones for this characteristic enhancement pattern. These lesions may be associated with a venous angioma that show an adjacent flow void. Next, we will discuss the diagnosis of intradural extramedullary tumors, and we will start with meningiomas. These lesions are isointense on both T1 and T2 and are homogeneously enhancing. Classically, dural tails of contrast enhancement are almost always noted. Intraspinal meningiomas become symptomatic and present long before bony changes occur, as compared to lesions in other locations. Schwannomas on CT scans are isodense to the spinal cord and have the possibility of hypodense cystic changes. Bony remodeling may be seen, such as enlargement of the neural foramen. Contrast enhancement is either seen peripherally or solidly within the lesions themselves. On MRI, there's a well-defined mass due to thin tumor capsule, and our isointense to hypointense on T1 enhances vividly and homogeneously upon contrast administration. Neurofibromas, on the other hand, unlike schwannomas, infiltrate the nerve roots, so there is no clear wall or capsule. A characteristic radiographic finding is the string of bead sign, seen when a neurofibroma involves several nerve roots. Cross-sectional images may have a typical target sign on T2 or stir sequences due to the nerve root being encased by the tumor entirely. Malignant peripheral nerve sheath tumors demonstrate T1 weighted imaging that is hyper-intense compared to the spinal cord. Isointensity on T2 is seen, and isointense nerve roots surrounded by mildly enhancing tumor tissue after contrast administration can be seen as well. Inclusion cysts, including dermoids and epidermoids, are most often located in the lumbosacral region and cauda equina. These lesions should be identified as having a sinus tract or not on the skin of the patient. Masses that resemble CSF on imaging are noted on MRI, and there may be calcifications and fat components as well on different sequences. These cysts usually demonstrate hypointensity on T1 and hyperintensity on T2, and they usually do not demonstrate avid enhancement with contrast. Unlike epidermoids, dermoids are less likely to show diffusion restriction. Atypical teratoid rhabdoid tumors are rare and infrequently occur in and around the spinal cord. They are located mostly in the cervical spine in very young children. Of the described cases, 91% are described and reported as being extramedullary. The diagnosis of neuroblastoma on CT can show a heterogeneous lesion with up to 90% demonstrating calcifications. May be found even pushing away the aorta from the vertebral bodies. On MR T1 weighted imaging, there is an iso to hypointense lesion with variable contrast enhancement. T2 weighted images reveal a heterogeneous signal intensity. Areas of hyperintensity may represent necrosis or cystic foci within these tumors. Extradural metastases on T1 generally are isointense and avidly contrast enhancing. Intraspinal lipomas are often hyperintense on T2 sequences. Hemorrhage and intratumoral cysts are rare compared to other spinal tumors. The presence of additional extraspinal lesions makes a metastatic tumor the most likely diagnosis for this presentation. Pathological bony fractures can also be seen. Moving on to spinal column tumors, we'll begin with the benign tumors. Osteoid osteitis and osteoblastomas on X-ray show osteosclerotic lesions with or without anitis. Osteoblastomas measure greater than 1.5 centimeters compared to osteoid osteomas, as previously discussed. CT reveals a hyperdense expansile lesion, often with bony destruction. Osteoblastomas on MRI have high T2 signal intensity compared to surrounding bone, and when noted within bone and muscle, can be demonstrated better and best on T2 signal. Langerhans cell histiocytosis demonstrates lytic lesions in the vertebral bodies with flattening of the bone. These vertebrae plana, pancake vertebral bodies, are pathognomonic for Langerhans cell histiocytosis. Nuclear bone scans show cold nodules compared to other lesions. Malignant tumors, such as Ewing sarcomas, have moth-eaten bony destruction patterns. X-ray demonstrates lytic or mixed lytic patterns to these lesions. Tiny perforations of the cortical bone can also be seen. Some of these lesions enhance, and signal change on MRI is notably variable within the different subtypes. Malignant tumors, such as osteosarcomas, reveal bony matrix on X-rays. Often, soft tissue masses are associated with these lesions. On MRI, they are hypointense on T1 with mineralization, neoplastic bone, and also hypointense on T2 sequences as well. Malignant tumors such as angiosarcomas present as purely lytic aggressive lesions. They're rarely associated with pathological fractures, but can be seen and may in fact affect the posterior elements classically. On MRI, lobulated lesions that are expansile and destructive are demonstrated for angiosarcomas. Giant cell tumors on X-ray reveal poorly differentiated lytic lesions that are generally confined to the vertebral bodies. They are associated with pathological compression fractures. On MRI, they are hypointense in T1 and T2, but too avidly enhanced with contrast. Scintigraphy demonstrates delayed increased uptake in the periphery of these lesions. Chordomas, most often found in the sacrococcygeal area or at the craniocervical junction, on X-ray demonstrate radiolucency with sclerotic margins. CT demonstrates lytic lesions, and on MRI show high intensity on T2 weighted images. Contrast enhancement and hyperintensity on T2 with fatty elements and hypointensity with calcifications can also be seen. Next, we'll move on to the section of treatment of these different types of tumor subtypes, starting with intramedullary tumors. The initial management currently is always surgical. Resection of greater than 80% of these lesions in children with low-grade tumors imparts a 70% or greater 5-year event-free survival. 5-ALA has recently been used to demonstrate the tumor margins intraoperatively and to support more complete resections of these lesions safely. Modern surgical equipment and techniques can also minimize the surgical morbidity, including intraoperative monitoring and neuronavigation. In general, only the solid portion of an intramedullary tumor needs to be removed through a midline incision, a laminectomy, and a durotomy, often done after placing epidural electrodes for monitoring. Myelotomy is performed over the entire length of the spinal tumor, but should start with a preliminary identification through a smaller area. However, full resection will require a larger myelotomy as the dissection and resection continue. Ideally, a frozen section examination is first performed and guides the surgical plan. Treatment of intradural extramedullary tumors usually consists of surgical resection. However, surgery may be delayed when the clinical setting strongly suggests an indolent, clinically insignificant tumor, such as with nerve sheath tumors that are asymptomatic. The dura is opened over the tumor's dorsal surface, and for dumbbell-shaped tumors, such as neurofibromas and schwannomas, a T-shaped opening with a leg extending laterally to expose the tumor relationship to the nerve root is used. A biopsy of the tumor is done on initial frozen section, guides further resection. The surface of the tumor is mapped using electrical stimulation to confirm that no rootlets remain unseparated and that the entering root is to be removed with the neurofibroma. All other nerve roots should be separated off the lesion for it to be removed en bloc. The dura is carefully inspected when a meningioma resection is performed and cauterized as needed to remove any still adherent tumor cells. For dermoid cysts and epidermoids, they are inclusion cysts. Avoid any injury or rupture to the cyst's capsule during dissection because a spread and dissemination of the contents of the cyst may cause an aseptic meningitis in patients. For extradural tumors that are confined to the extradural space, they are usually operated on only when their mass effect is causing clinical symptomatology. Only simple or ultrasonic aspiration for removal of these tumors is typically required, and the goal of surgery is really decompression with removal of easily accessible tumors. For spinal column tumors, benign tumors may be observed if asymptomatic, and ideally, if they are symptomatic and require surgical resection, a dorsal approach provides access to the tumors without destabilizing the spine. However, given the anatomy and morphology of these lesions, in some cases, lateral or ventral approaches to the spine are indicated, and instrumentation may be required if destabilization is to occur for full resection of these lesions. En bloc resection are increasingly common for tumors of the spinal column when complete resection is desired, and with the assistance of our spinal colleagues, different modes of stabilization of the spine may be required and utilized as needed. Malignant tumors typically require surgery in the setting of an unacceptable compression of neural elements. The various sarcomas and giant cell tumors are often soft cellular tumors that lend themselves to aspiration or curettage. Teratomas, chordomas, and chondrosarcomas differ in their ease of resection and responsiveness to adjuvant therapies, and these subtypes must be differentiated in order to provide for the best outcomes and management strategies for our patients. For Ewing sarcomas, a 75% survival for patients is noted with wide surgical margins, as reported in the literature. Now, briefly to discuss adjuvant treatments for surgical resection in intramedullary spinal cord tumors. Traditionally, intramedullary spinal cord tumors have been managed with radiation, possibly augmented by surgical biopsy or decompression. However, recently, and over the last couple of decades, with safer operative techniques, the efficacy of aggressive resection of greater than 80% of these lesions matches that of surgery plus radiation. And radiation has been shown to introduce additional risk of injury to the growing spine and the introduction of second malignancies, and thus is no longer favored for these lesions, whereas surgical resection, with its increased safety profile, has become the standard of care. For intradural extramedullary tumors, while radiotherapy has not been shown to significantly improve overall survival, it is thought to promote local control. Chemotherapy is reserved for patients with widely metastatic disease, and there may be some potential for MEK inhibitors for managing plexiform neurofibromas affecting the spine. In cases where gross total resection of an intradural meningioma is not possible, craniospinal irradiation and chemotherapy are indicated. Adjuvant treatments in the management of extramedullary tumors such as osteosarcomas, chordomas, chondrosarcomas, and Ewing sarcomas are currently discussed, and recently proton beam therapy has been demonstrated to have improved outcomes and management plans for children with these lesions. Other adjuvant therapies include bevacizumab, which showed some mild promise with cystic ependymomas with moderate clinical improvement, although much more work needs to be done. Several other medications, including tyrosine kinase inhibitors, as well as histone deacylate inhibitors, have been trialed both in VHL-related hemangioblastomas with varying degrees of success. The treatment of malignant spinal cord tumors with classic chemotherapy has largely been anecdotal. For the other types of extradural tumors, we'll discuss adjuvant therapies on this slide. Radiation therapy is often reserved for patients requiring adjuvant treatment after surgical resection or chemotherapy for neuroblastomas due to the risk of radiation therapy to bony growth in young children. The choice of chemotherapy versus surgery for neuroblastomas as a first-line treatment is most often based on the extent of disease, with surgery favored for lesions that can be completely resected. Chemotherapy should be adjusted based on the different types of lymphoma and leukemia and is currently the standard of care for these lesions. For metastases, they are usually treated with decompression and surgical debulking, followed by definitive treatment with chemotherapy or radiation therapy. Next, we'll provide some limited data regarding adjuvant treatments in spinal column tumors. For osteoblastomas, there's only 2 case reports using chemotherapy to manage recurrent disease as opposed to repeat surgical resection. No reports of using chemotherapy or radiation to augment the surgical management of osteochondromas is reported. Radiation has been used to manage aneurysmal bone cysts that are unresectable, and they may be responsive in the future to human monoclonal antibody denosumab that targets rank L. Langerhans histiocytosis can be managed with chemotherapy, and imatinib, a tyrosine kinase inhibitor, has been used successfully for local control of chordomas in certain patients. Now we'll discuss outcomes, starting with intramedullary spinal cord tumors. The event-free survival for these children who undergo greater than 80% resection of their tumors is 70% at 10 years. With subtotal resection, progression-free survival is 45% and 38% in 5 and 10 years respectively, and the overall survival is 87%, 66%, and 38% at 5, 10, and 20 years respectively. There is a contradistinction to children with high-grade tumors where the 5 and 10-year survival is significantly worse at 18 and 20%, and the 10-year event-free survival is less than 20% for these lesions both managed surgically and with adjuvant treatments. Functionally, the children with benign intramedullary spinal cord tumors seem to do reasonably well, with greater than 60% functional independence at a mean follow-up of 13 years. A systematic review of 53 pediatric patients with glioblastoma of the spine demonstrated that younger patients who were less than 7 years old had better overall survival, on average of 13 months, than patients over 12 years of age who had a mean 9-month survival. Gross total resection did not demonstrate prolonged overall survival compared to those who underwent partial resection alone. However, patients with gross total resection followed by radiation therapy showed improved survival compared to those who went subtotal resection followed by radiation therapy. Next, we'll discuss the outcomes of intradural extramedullary tumors. Gross total resection of these tumors remains the current standard of care and is curative for most of these lesions. A twofold decrease in recurrence rate in patients receiving a gross total resection versus a subtotal resection has been reported. Surgical resection in the case of malignant lesions may not be curative, however, even after gross total resection, and other adjuvant therapies may be required. Surgery, radiation therapy, and/or chemotherapy have all been shown to be effective in the treatment of intraspinal neuroblastomas. Some cases series have shown that significant reduction in the need for surgical decompression when chemotherapy was used as a first-line treatment. Favorable outcomes have been reported with this multimodal treatment, noting that approximately 70% plus or minus 5% overall 5-year survival rate for these lesions using a multimodal approach. Benign spinal cord tumors have fairly good outcomes. While spontaneous resolution occurs in the majority of these lesions, some require surgical resection. Treatment with complete surgical resection for any of the benign tumors of the spinal cord is considered curative. Resolution of pain has also been seen in 3/4 to all patients with no recurrence noted at 10-year follow-up. On the other hand, malignant spinal cord tumors demonstrate recent advances in chemotherapy and radiation that have significantly improved previously poor outcomes. Patients with chordomas continue to have a poor prognosis. However, recent reports document that overall survival rates at 5 years have improved from classical treatment to 50 to 80%. In the case of sacrococcygeal teratomas, however, multiple studies have been published reporting as high as 94% 5-year survival rate after surgery and adjuvant chemotherapy. In summary, progress continues to be made in our understanding of tumors affecting the spine and spinal cord in children. Diagnostic tools continue to improve, as do tools for managing these tumors. As we delve deeper into the cytogenetics of these tumors, newer therapeutics will invariably become part of our treatment armamentarium. We should expect a continuation in the trends of longer survival and the use of multimodal therapeutics for longer-term control of these tumors in children in the future. I thank you for your time and attention. My name is Andrew Kobitz, and I hope this PowerPoint presentation has aided in your understanding of spinal cord tumors in children.